Coagulation disorders involve abnormalities in the normal hemostatic process. Normal hemostasis is a regulated and dynamic balance between thrombin-stimulated fibrin clot formation and plasmin-induced clot lysis. It consists of three phases: vascular phase, platelet phase, and coagulation phase. The vascular phase is a brief contraction of blood vessels at the site of vessel injury, helping to minimize blood loss. The platelet phase is activated at the site of vascular injury to form a platelet plug and involves two main processes: adhesion and aggregation. During adhesion, platelets bind to the disrupted endothelium through the platelet surface receptor GPIB, which attaches to von Willebrand factor, VWF. During aggregation, platelets clump together at the site of bleeding through the binding of the GPIB 3A receptor on their surface. Platelet function during this phase is monitored by bleeding time. The coagulation phase follows and is divided into the extrinsic and intrinsic pathways, both of which converge into the common pathway. The extrinsic pathway involves fewer factors, primarily factor 7 and tissue factor, and is monitored by the prothrombin time, PT. The intrinsic pathway involves multiple factors, including factors 8, 9, 11, and 12, and is monitored by the partial thromboplastin time, PTT. Both pathways merge into the common pathway involving factors 1, 2, X, and 13, leading to the formation of a stable fibrin clot. Tissue plasminogen activators are contraindicated in situations with active bleeding or high bleeding risk. The presence of a known intracranial lesion, recent trauma or surgery to the spine or brain within the past 2 months, and a history of hemorrhagic stroke or recent non-hemorrhagic stroke within the past 3 months. When bleeding dysfunction occurs, bleeding time, PT, and/or PTT may be prolonged, depending on the underlying cause. Vascular injury leads to the release of von Willebrand factor and tissue factor from subendothelial vessel walls. VWF facilitates platelet adhesion and aggregation to form a platelet plug, while tissue factor triggers the coagulation cascade through the extrinsic pathway by activating factor 7. Together, these mechanisms stabilize the clot and stop bleeding. Enteric bacteria in the gut synthesize vitamin K, which is essential for the synthesis of clotting factors 2, 7, 9, and X. Neonates lack these bacteria and are therefore prone to bleeding, which is why vitamin K is routinely administered at birth. Similarly, in children and adults, prolonged use of antibiotics can disrupt normal intestinal flora and lead to decreased vitamin K production, increasing the risk of bleeding. Ultimately, the platelet plug and the coagulation cascade together produce a stable fibrin mesh that reinforces the clot and prevents further blood loss. Features of bleeding disorders can be broadly divided into platelet disorders and coagulation disorders. In platelet disorders, bleeding typically occurs from the skin and mucous membranes, such as epistaxis, gum bleeding, or gastrointestinal bleeding. Petechiae are commonly present, and ecchymoses tend to be small and superficial. Hemarthrosis, or deep muscle bleeding, is generally absent. The onset of bleeding after surgery or trauma is immediate in platelet disorders. In contrast, coagulation disorders usually involve bleeding deep within soft tissues, including joints and muscles. Petechiae are absent, but ecchymoses are large and deep. Hemarthrosis and muscle bleeding are common features. The onset of bleeding following surgery or trauma is delayed, typically appearing 1 to 2 days later. Coagulation pharmacology involves drugs that affect the coagulation cascade without changing platelet count. Unfractionated heparin. This drug activates antithrombin, which inactivates factor XA, thrombin, I, and other proteases. It prolongs the partial thromboplastin time, PTT. Protamine sulfate serves as its antidote. It is safe for use in pregnancy and is often used as a bridge to warfarin therapy. A potential adverse effect is heparin-induced thrombocytopenia, HIT. Warfarin inhibits the synthesis of vitamin K, dependent coagulation factors 2, 7, 9, and X, and to a lesser extent, protein C and S by blocking vitamin K epoxide reductase. It increases prothrombin time, PT, and the international normalized ratio, INR. For rapid reversal, prothrombin complex concentrate, PCC, is used, while vitamin K is given for slower reversal. Warfarin is teratogenic. Therefore, low molecular weight heparin, LMWH, is preferred in pregnancy. Tissue plasminogen activators, TPAs drugs such as alteplase, retaplase, and tenecteplase aid in the conversion of plasminogen to plasmin, which breaks down fibrin clots. They increase PT and PTT without affecting platelet count. Overdose toxicity is managed with aminocaproic acid, tranexamic acid, and fresh frozen plasma, FFP, to reduce bleeding risk. TPAs may cause angioedema as a side effect. Factor XA inhibitors, apixaban, rivaroxaban, these direct oral anticoagulants, DOACs, inhibit factor XA directly. PT and PTT are not typically monitored. The reversal agent for these drugs is andexanet alpha. Low molecular weight heparin, LMWH, enoxaparin, dalteparin, LMWH primarily inhibits factor XA. Anti-factor XA activity can be measured but is not routinely monitored by PTT. Protamine can partially reverse LMWH, though it is less effective than with unfractionated heparin. LMWH has better bioavailability, a longer half-life, 2 to 4 times that of UFH, and a lower risk of hit. It is usually administered subcutaneously. Direct thrombin inhibitors, dabigatran, argatroban, bivalirudin, these drugs directly inhibit thrombin, factor II, and are classified as DOACs. PT and PTT are not routinely monitored. Dabigatran's reversal agent is idarusazumab, while other direct thrombin inhibitors currently lack specific reversal agents. Argatroban is commonly used for anticoagulation in patients with HIT instead of heparin. Glycoprotein IIB3A inhibitors, abciximab, eptifibatide, tirofiban, these agents reversibly bind to the GPIIB3A receptor on activated platelets, preventing platelet aggregation. PT and PTT are not monitored. Abciximab is derived from monoclonal antibody fragments. A heparin to warfarin bridge is necessary because the onset of anticoagulation with warfarin is slow. Heparin is started concurrently and continued until the warfarin dose achieves a therapeutic international normalized ratio, INR, between 2 and 3. This overlap prevents early hypercoagulability caused by the rapid depletion of proteins C and S, which have shorter half-lives than the other vitamin K, dependent factors 2, 7, 9, and X. The temporary decrease in these natural anticoagulants can lead to a transient prothrombotic state before warfarin's full anticoagulant effect develops. Warfarin inhibits vitamin K epoxide reductase, while direct oral anticoagulants, DOACs, inhibit either factor XA or thrombin directly. Warfarin requires laboratory monitoring through prothrombin time, PT, and international normalized ratio, INR, whereas DOACs generally do not need regular monitoring. The antidotes for warfarin are vitamin K, fresh frozen plasma, FFP, and prothrombin complex concentrate, PCC. For DOACs, idarusazumab reverses dabigatran, and andexanet alpha reverses factor XA inhibitors. Warfarin has a long half-life with a slow onset and prolonged offset, whereas DOACs have a short half-life with rapid onset and short offset. Warfarin is metabolized hepatically, while DOACs are primarily renally excreted. Warfarin is preferred in patients with mechanical heart valves, but should be avoided in those with poor medication adherence or chronic kidney disease, CKD. DOACs are preferred for pregnant patients and those with cirrhosis. Warfarin is relatively inexpensive, whereas DOACs are more costly. Management of warfarin therapy involves careful adjustment based on INR levels and the presence or absence of bleeding. In cases of active bleeding, warfarin should be discontinued immediately, and intravenous vitamin K, along with prothrombin complex concentrate, PCC, should be administered. The INR should be monitored closely until stabilization is achieved. If the INR is greater than 10 without bleeding, warfarin should be discontinued and oral vitamin K should be given, with frequent INR monitoring to ensure it returns to the therapeutic range. When the INR is between 4.5 and 10 without bleeding, warfarin should be temporarily held for a few doses, and low-dose oral vitamin K may be administered to lower the INR more rapidly. For patients with an INR less than 4.5 without bleeding, the next dose of warfarin should be withheld, and the maintenance dose should be readjusted according to follow-up INR results. Key fact: the liver is the machinery responsible for synthesizing the vitamin K-dependent coagulation factors. Liver disease can therefore increase the bleeding tendency. Clinical case: an 8-year-old boy from Eastern Europe presents with severe swelling and warmth of his knee several hours after a minor bump against a lamppost. What is the most accurate diagnostic test for his presentation? This boy probably has X-linked hemophilia, most common, which is most accurately diagnosed with a specific factor VIII level. Transfusion products are used to replace specific blood components depending on the patient's clinical needs. Each product has unique compositions, indications, and complications. Fresh frozen plasma, FFP, contains clotting factors 2, V, 7, 11, and fibrinogen at normal plasma concentration. It is indicated for inherited coagulation factor disorders, ongoing bleeding due to liver disease, vitamin K deficiency, or warfarin anticoagulation. Complications include transfusion-related acute lung injury, TRALI, and transfusion-associated circulatory overload, TACO. FFP requires ABO compatibility and is relatively high in cost. Prothrombin complex concentrate, PCC, contains factors 2, 7, 9, and X, as well as proteins C and S. It is indicated for rapid reversal of warfarin anticoagulation or bleeding due to vitamin K deficiency, providing correction much faster than FFP. It has fewer volume-related complications, but carries a risk of thrombosis. PCC does not require ABO compatibility and is low in cost. Cryoprecipitate is rich in factor VIII, von Willebrand factor, VWF, and fibrinogen. It is used to treat fibrinogen disorders, von Willebrand disease, disseminated intravascular coagulation, DC, liver disease, and uremic bleeding. Like PCC, it has fewer complications related to volume overload compared to FFP, but is relatively high in cost. ABO compatibility is required. Packed red blood cells, PRBCs, are indicated for hemoglobin levels less than 7 GDL or less than 8 GDL in patients with coronary artery disease, anemia, or acute blood loss causing hemodynamic instability. Each unit of PRBC raises hemoglobin by approximately 1 GDL. Complications include hemolytic reactions, TRALI, TACO, and allergic reactions. PRBCs require ABO compatibility and are low in cost. Platelet transfusions are indicated when the platelet count is less than 10,000 mUL in non-bleeding patients, less than 20,000 mUL in those who are bleeding or undergoing procedures, or less than 50,000 mUL prior to surgery. Each unit increases the platelet count by approximately 6,000 mUL. Complications include allergic reactions, TRALI, and TACO. Platelets do not require ABO compatibility and are low in cost. Hemophilia is a clotting factor deficiency disorder involving factors 8, hemophilia, accounting for about 80% of cases, 9, hemophilia B, and 11, hemophilia C, which increases the tendency to bleed. Hemophilia A and B are X-linked recessive genetic disorders occurring in approximately 1 in 10,000 male births. Rarely, hemophilia may be acquired due to the development of antibodies against clotting factors, often in association with autoimmune diseases, lymphoproliferative disorders, or postpartum states. Hemophilia A and B are inherited as X-linked recessive traits, whereas hemophilia C is more common among individuals of Ashkenazi Jewish descent and is typically autosomal recessive. Clinically, hemophilia presents in young males, often around 1 to 2 years of age when they begin to walk, with spontaneous bleeding in soft tissues, muscles, and joints, hemarthrosis. Recurrent hemarthrosis can lead to chronic arthropathy and joint destruction due to hemosiderin deposition, cartilage and synovial damage, and fibrosis. X-ray of the affected joint may show calcifications. Other bleeding manifestations include spontaneous intracerebral, renal, retroperitoneal, and gastrointestinal hemorrhages. Mild cases may remain asymptomatic until significant trauma, surgery, or dental procedures trigger major bleeding episodes. Diagnosis reveals a prolonged activated partial thromboplastin time, PTT, since factors 8, 9, and 11 belong to the intrinsic coagulation pathway. Prothrombin time, PT, and bleeding time remain normal. The best initial diagnostic test is a mixing study, where patient plasma is mixed with normal plasma. In hemophilia, this corrects the PTT because normal plasma provides the missing factor. Prolonged activated partial thromboplastin time, APTT, requires a mixing test using control plasma and the patient's plasma. If the APTT corrects, it indicates a factor deficiency, and the next step is to measure factors 8, 9, 11, and von Willebrand factor, VWF. If these factor levels are normal, further workup is needed to identify the cause. If they are low, a specific factor deficiency, such as hemophilia B or C, is confirmed. If the APTT does not correct or only partially corrects, this suggests the presence of an inhibitor, and additional analysis is required to determine whether the inhibitor is time or temperature dependent. If it is time or temperature dependent, factor 8 and its inhibitor should be measured. A low factor 8 level indicates factor 8 deficiency, while the detection of an inhibitor confirms the presence of an acquired inhibitor against factor 8. If the mixing test shows no correction and is not time or temperature dependent, a test for lupus anticoagulant should be performed. A positive result confirms lupus anticoagulant, whereas a negative result warrants further testing of factor 8 and inhibitors to identify the underlying cause. However, in acquired hemophilia, PTT fails to correct due to circulating antibodies that neutralize the clotting factor. The most accurate diagnostic test is a specific factor assay to quantify factors 8, 9, 11, and 12. Cryoprecipitate consists mainly of factor 8 and fibrinogen, with smaller concentrations of factor 13, von Willebrand factor, VWF, and fibronectin. It serves as a more concentrated source of factor 8 and fibrinogen than fresh frozen plasma, FFP. In cases where bleeding is severe or the factor level is less than or equal to 1% of normal, immediate transfusion with the missing factor is required. If the specific factor is unavailable, cryoprecipitate can be used as an alternative. When bleeding is not severe and the factor level is greater than 5% of normal, mild, or between 1% and 5% of normal, moderate, hemophilia may be treated with desmopressin, which stimulates the release of factor 8 from endothelial cells. Genetic counseling is recommended to identify and screen other potentially affected family members. The cornerstone of modern management for severe hemophilia A is the prophylactic administration of clotting factor concentrates to prevent bleeding episodes and long-term complications. Von Willebrand disease, VWD, is the most common inherited bleeding disorder, affecting approximately 1% of the population. It results from an autosomal dominant defect or deficiency in von Willebrand factor, VWF, which can also lead to decreased levels of factor 8, since VWF carries and stabilizes factor 8 in circulation. The three primary functions of VWF are to mediate platelet adhesion to the exposed subendothelium, promote platelet aggregation, and bind to factor 8 to prevent its degradation. The symptoms of VWD are generally milder than those of hemophilia and arise from both platelet dysfunction and reduced factor 8 activity. The most common form, type 1 VWD, involve a mild to moderate quantitative deficiency of VWF. Type 2 VWD is characterized by qualitative defects in VWF, while type 3 VWD represents a complete quantitative loss of VWF. A special form known as Haid syndrome is associated with aortic stenosis, gastrointestinal bleeding, and acquired von Willebrand syndrome, which develops due to increased shear stress in circulation causing cleavage and loss of VWF multimers. Key fact: von Willebrand disease, VWD, often presents with a positive family history of bleeding tendency, a normal platelet count, and clinical manifestations of platelet dysfunction such as epistaxis, menorrhagia, and other mucosal bleeding episodes. It typically presents in childhood with recurrent and prolonged mucosal bleeding from sites like the nose, gums, and gingiva, as well as excessive bleeding after dental or surgical procedures. A family history of similar symptoms is common, and symptoms frequently worsen with the use of acetylsalicylic acid, ASA. Key fact: reduced agglutination is seen on the ristositine cofactor assay, which detects von Willebrand factor dysfunction. This finding is diagnostic of VWD and helps distinguish it from other platelet disorders such as Bernard-Soulier syndrome. The best initial diagnostic test for VWD is the ristositine cofactor assay, which measures the ability of VWF in the patient's plasma to agglutinate platelets. An additional diagnostic test is the VWF antigen level, which may be decreased. Factor VIII levels can also be measured to assess VWF dysfunction, but this test is less specific. In the initial bleeding workup, an increased bleeding time is seen in all types of VWD. Partial thromboplastin time, PTT, may also be prolonged due to low factor VIII levels, similar to hemophilia, while prothrombin time, PT, and platelet count remain normal. ASA use increases the risk of bleeding in patients with VWD and should be avoided. The best initial treatment for mild to moderate VWD is desmopressin, DAP, which promotes the release of endogenous VWF from endothelial storage sites. In more severe cases, during major bleeds or surgeries, or in patients unresponsive to desmopressin, such as those with certain type 2 variants, treatment involves replacement therapy with VWF factor VIII concentrates. Antifibrinolytic agents, such as aminocaproic acid and tranexamic acid, may be used as adjuncts to control bleeding from mucosal sites, including the nose, oropharynx, and urogenital tract. Menorrhagia can be controlled with oral contraceptive pills, OCPs. Drugs to avoid include ASA, nonsteroidal anti-inflammatory drugs, NSAIDs, and platelet function inhibitors due to their potential to worsen bleeding. Von Willebrand disease types 1 and 2 are generally inherited in an autosomal dominant pattern, whereas type 3 VWD is inherited in an autosomal recessive pattern.